Mike finished his cardiac surgical residency here at Toronto General Hospital, with a focus on heart transplant and aortic surgery. He then completed his fellowship here at SickKids in congenital cardiac surgery with an emphasis on ACHD operations. He is currently completing his research in outcomes following tricuspid valve surgery. He enjoys golf and likes to fish in the little spare time that he gets. Thank you very much for presenting, Mike.
Well, thank you very much for that. And ladies and gentlemen, thanks very much for the opportunity to present on the history of Fontan procedure. The amount of work that's gone into the development of this operation is incredible. And so I'm very excited to share with you some of the major findings that I've come across in my readings. And a special thanks to Dr. Barron and Honjo for going over my slides and providing me with their feedback. So the classic Fontan procedure, as you know, was introduced in 1968 to treat patients with tricuspid atresia, and was the first clinically successful complete bypass of the right heart in 1971, being reported in journal Thorax. So in brief, for Fontan physiology, regarding Fontan physiology, in normal biventricular heart, the systemic and pulmonary circulations are each supported by a ventricle, whereas in a Fontan connection, the systemic and pulmonary circulations are in serial arrangement without the interposition of normal ventricle. So this is a cartoon that shows some of the major different types of Fontan circulation, starting with the Atriopulmonary connection in the left, and the total Cavopulmonary connection types with the lateral tunnel and the extracardiac variants in the middle and to the right. So the Fontan procedure itself was subsequently applied to a range of complex congenital heart malformations characterized by one functional ventricular chamber where biventricular repair was not possible. But interestingly, the ideas that led to the Fontan circulation actually start much earlier. And this is Dr. Harvey in 1628, who described the continual rising and falling of lungs in respiration must open and close the vessels and porosities as in a sponge or a thing of similar structure when it is compressed and allowed to expand. And so the lung expansion attracts air and blood. And so this is Magendie in 1842, who noted that when lungs expand, they can attract air and blood at the same time. Lichtenheim in 1876 discovered that inspiration and insufflation under positive pressure have opposite effects on pulmonary artery pressure. And his contemporary Darnserval in 1877 demonstrated distension of thorax changes the PA pressure and increases flow through lungs. In 1943, Isaac Starr demonstrated that damage to the pumping capability of the RV actually did not result in venous congestion and hypertension, and so thus he hypothesizes that perhaps the right heart may not be necessary for pulmonary perfusion. And Rothbarb in 1949 corroborated the findings and demonstrated that venous pressure is sufficient to provide flow to lungs without the benefit of pumping action of the RV. So comes the advent of the Cavopulmonary shunt. This is Dr. Carlon in 1950, who in a canine model introduced the Cavopulmonary shunt using the azygous vein. And this is the Carlon shunt, which was a direct end-to-end anastomosis between the azygous vein and the RPA with an SVC ligation at the SVC-RA junction, and thus creating a partial right heart bypass. And so comes later Dr. Glenn, who demonstrates one of the first clinical experiences with Cavopulmonary anastomosis, the so-called Glenn shunt in 1958, which was an end-to-side anastomosis of the RPA to the SVC with proximal SVC ligation at the SVC-RA junction. It was noted that the Glenn shunt can increase blood flow to lungs. It can also increase systemic saturation without the increase in volume load on the functionally single ventricle. Some modifications were introduced to the Cavopulmonary shunt with Dr. Dogliotti and colleagues in 1961. when they introduce a double end-to-side anastomosis of the SVC with both sides of the RPA, with ligation of the SVC at the RA junction, which allowed flow into both lungs from the SVC. And interestingly, they make a passing reference to this surgeon, Dr. Bakulov, who was the chief of cardiac surgery in Moscow in the former USSR at the time, who actually, as early as 1959, proposed right heart exclusion with the SVC to RPA and IVC to LPA anastomoses. His idea really gained popularity thanks to Darbinian in 1957 and for performing some of the first successful Cavopulmonary shunt experiments in Russia. And he used what was called a Donetsky's ring, which was a stainless steel ring, which allowed end-to-side anastomosis between vessels. And by using Donetsky's ring, an anastomosis could be completed within seconds. And this was the technique that was implemented in the vast majority of Darbinian's study that was published at the time. And so based on this technique comes Dr. Meshalkin, who actually performed the first successful clinical cavopulmonary anastomosis in the world on April 3rd, 1956, which was 2 years before the Glenn shunt was introduced. And his technique was heavily influenced by the Darbinian technique that was seen a few slides earlier. And it was characterized by without using the use of temporary azygos to the RA shunt. And so overall, the summary of this is that there were many, many experiments that were conducted for the purpose of bypassing the right heart. And as many as 40 different experimental procedures were carried out, as a matter of fact. The vast majority of these were physiological studies to test the feasibility of either partial or complete right heart bypass. And so the conclusion from these procedures, these experiments, was that yes, it is indeed possible to perform a complete right heart bypass, and that blood driven by venous pressure alone may pass the pulmonary circulation unhindered. And so this concept laid an invaluable foundation for the upcoming operations such as the Fontan, the Kreutzer, and the Bjork. So we come to the classic Fontan procedure, which was introduced in 1971 by Dr. Fontan, which was the first clinically successful complete bypass of the right heart in tricuspid atresia. Briefly about Francis Fontan, he was the first to perform the setting procedure in France. He performed the 4th heart transplant in France, and he played an integral role in founding of the European Association for Cardiothoracic Surgery. He was also a son of a cyclist, and this is Victor Fontan, his father, who's photographed here during Tour de France in 1929, and you can appreciate the broken bicycle in the photograph. Fontan was also a resident of Bordeaux, and he liked golf, and he also enjoyed good wine, and was involved in the renovation of Chateau L'Hermitage in Bordeaux, and quite impressively even went on to winning Prix d'Excellence in wine festivals as well, for those of you who appreciate good wine and may be interested. So going back to the classic Fontan procedure itself, it was basically, it consisted of cavopulmonary anastomosis between the SVC and RPA, and the IVC flow into the LPA was done by using an interposition aortic valvular homograft to link the RPA and the right atrium. In the early days of Fontan, the power source other than main ventricular chamber was believed to be necessary to serve the pulmonary circulation. And this was felt necessary, the additional work by something other than the ventricle was felt to be necessary because of the higher PA pressure than the left atrial pressure. And so because of this, in most cases of earlier cases of Fontan, the right atrium was connected to the pulmonary artery to serve as this power source, which was based on the concept that hypertrophied right atrium in tricuspid atresia could act as a pump. Fontan could be also credited for coming up with the so-called 10 Fontan Commandments, which were basically the selection criteria for patients with tricuspid atresia at the time to select sort of the ideal candidates to undergo a Fontan operation. And as we know, just like the operation itself, the so-called Fontan Commandments have also undergone revisions throughout the years. Interestingly, without being aware of Fontan's work, Dr. Kreutzer in 1973, he described his experience of encountering a Sinos 3-year-old boy with tricuspid atresia who had undergone a Waterston shunt that became occluded with a subsequent thrombosis of the RPA. He described an atriopulmonary connection using a homograph between the right atrium and the MPA without a glen and without placing a valve in the IVC. He had a fenestration in the atrial septum, and this operation, what later became to be known as the Kreutzer procedure, was the first fenestrated total pulmonary ventricular bypass. There were, however, problems associated with the classic Fontan and Kreutzer procedures in that both techniques involved using conduits and prosthetic valves, which in themselves had significant limitation with growth potential and durability of the operation. And so came the Bjork procedure in 1979, which was a direct RA to RV connection by utilizing a ventriculotomy and pericardial patch to roof decommunication, as seen in the right cartoon, and in the left one, alternatively, as can be used with a valved conduit as well as a modification. The advantage of the Bjork procedure is that it can incorporate the right ventricle as a pumping chamber if it's not too hypoplastic, and also has the benefit of maintaining the pulmonary valve and the main PA in normal position as well. However, with all of these atriopulmonary connection type Fontans, there were problems, and it was that over time, the right atrium would dilate and lose its propelling force. And the progressive RA dilatation would be associated with things like atrial tachyarrhythmias and thrombosis. So comes Dr. Delaval in 1996, using computational fluid dynamics. He demonstrates that having the right atrium in the subpulmonary circulation can often be disadvantageous because of the right atrial dilatation that will lead to energy loss and flow disturbances. So as a result of these findings, the atriopulmonary connection became largely historical, almost completely abandoned nowadays because of poor results and high incidence of reoperations. So comes the development of the total cavopulmonary type connection, of which there's the lateral tunnel variant in the left and the extracardiac conduit variant in the right. The lateral tunnel technique was introduced by Dr. Delaval in 1988, which was an anti-side anastomosis of the SVC to an undivided RPA, and using composite intra-atrial tunnel by incorporating the posterior wall of the right atrium and prosthetic patch to channel the IVC flow into the pulmonary artery, and that's seen on the left. And alternatively, an intra-atrial conduit could be used anastomosing directly to the MPA as a variation of this operation. And the advantages of the lateral tunnel type connection is that it's simpler and more reproducible. It also tends to be away from the AV node and allows maintaining the growth potential for the right atrium and the KV, which have been more ideal characteristics for younger patient population. In addition, most of the right atrium remained at low pressure, which would have meant that there's a reduction in the risk of atrial arrhythmias. There's also reduction in turbulence with a decrease in the energy loss that would ultimately minimize the risk of atrial thrombosis. And excellent hemodynamic profile was also documented using this type of connection with minimal gradients throughout all the connections as well. The disadvantages of the lateral tunnel would be that there must be some component of atrial distension. And there were concerns regarding postoperative arrhythmias, possibly as a result of presence of atrial suture lines. And from the technical perspective, the need for cardiopulmonary bypass, for cardioplegic or fibrillatory arrest to construct the intra-atrial baffle portion of the operation. The extracardiac conduit version was introduced by Dr. Humes in 1988, which was subsequently popularized by Marcelletti. And basically, the Marcelletti version is shown on the left. The Puga variation, you can appreciate that the location of the vascular anastomosis on the RPA is on the other side of the BCPS with respect to Marcelletti versus the Puga. And the types of extracardiac conduits that have been used in the that have been described in the literature consist of the PTFE conduit, the vascular conduit, as well as in situ pericardial conduit as well. The PTFE conduit is a relatively simple technique that involves an interposition vascular graft between the IVC and the RPA. And this would allow more uniform flow with less turbulence and minimal energy loss. There would also be less risk of pulmonary venous and systemic AV valve obstruction as well. It also avoids, protects the RA from being exposed to high venous pressures. There's also less atrial suture lines, possibly none if there's no fenestration involved, and which may lead to less atrial dilatation and arrhythmias. And from technical perspective, this can be done without cardiopulmonary bypass, without cardioplegic or fibrillatory arrest. Some of the disadvantages of the PTFE conduit technique is that there is an absence of growth potential, and so this may require a relatively older patient selection. And of course, in setting of fenestration, there may be a risk of systemic thromboembolism as well. In terms of the in situ pericardial conduit, which was introduced in 1992, it uses autologous pericardial flap to construct an extracardiac conduit, as seen in the diagram here. So basically, the posteromedial portion of the pericardium is maintained in situ, and a lateral incision that's perpendicular to the SVC and IVC is created, and thus a pericardial flap is constructed, which is then sewn to the IVC, RPA, and to the RA wall to form an extracardiac tube. So in essence, it's the pericardium that's forming the lateral wall and the right atrium that's forming the medial wall. The advantage of the in situ pericardial technique is there's growth potential of the autologous pericardial conduit, and also a lower risk of thrombosis and infectious complications documented in the literature. With the disadvantages being that atrial suture line may increase risk of atrial flutter. And because of the nature of the in situ pericardial flap construction, there is an inherent risk of phrenic nerve injury, as well as risk of ipsilateral pulmonary venous obstruction and compression secondary to higher pressure in the extracardiac conduit. Both the lateral tunnel and the extracardiac conduits have demonstrated long-term outcomes with an overall operative mortality in the ranges of 2 to 13% in the literature without a significant difference between the two. And so in the current era, both types are being used depending on the institutional preferences and experiences. And of course, last but not least, another further milestone in the evolution of Fontan involves fenestration. The idea is to allow controlled right to left atrial shunt, which was applied to improve the early surgical outcome, to maintain cardiac output in high-risk patients, especially during the phasic elevation of PVR. It was found that fenestration may be helpful in those who are undergoing concomitant procedures, single lung Fontan palliation, elevated PVR, increased TPG, and reduced systemic ventricular function. The disadvantages of fenestration is, of course, the potential risk of desaturation, as well as systemic embolization, and a possible need for reintervention in the future with variable policies for late closure amongst centers. So, as concluding thoughts, there have been many variations of the Fontan circulation that have been published in the literature to date, as exemplified by this diagram here. It's interesting to observe that the ideas leading to the Fontan circulation began very early, as early as 1628. Our understanding became better between the relationship between the respiration and pulmonary perfusion in as early as in the 1800s, and we were better aware that the RV function may not be as critical for pulmonary circulation, and we began to appreciate this in as early as 1940s. It took many physiologic experiments to test the feasibility of either the partial or total RV bypass, and these came in the form of the Cavopulmonary shunts, with their subsequent revisions throughout the 1950s and 60s, which ultimately led to the introduction of the classic Fontan procedure in 1971 to describe a complete bypass of right heart in tricuspid atresia. And of course, since the introduction of the classic Fontan procedure, there were numerous variations that occurred throughout. And so, starting with the Atriopulmonary Connection with their variants, the total Cavopulmonary Connection types with their variants, and of course, the introduction of fenestration as well. And so the evolution of Fontan represents a remarkable collaboration among specialists from many disciplines, including but not limited to surgery, cardiology, and physiology. And also the evolution of Fontan represents an incredible journey to become what is now one of the most common operations being performed in congenital cardiac surgery. Thank you.